neonatologists have gotten very good at keeping these children alive. They've largely done it by their expertise in disorders above the diaphragm, the inheritance and pulmonary survival. Nonetheless, this child, like so many children worldwide who are born at this gestational age, was given a lot of antibiotics at birth, largely empirically, and this child's first antimicrobial day of life was actually day of life 18. None of the indications for giving this child antibiotics were what we call incredibly high grade. The mother's pathology report from the placenta was, quote, chorioamnionitis, which is a nebulous diagnosis. When the child didn't get off the ventilator in the first week of life, and by the way, neonatologists are getting children off, instead of putting them on ventilators, they're getting them off the ventilator within a couple of days, which to those of us who've trained several decades ago is incomprehensible. This is fantastic. This child took about a week to get off, and everyone was worried something was going on. And the child had a persistently high white count. Nonetheless, the child, after a couple failed attempts at extubation, seems to be permanently extubated at day of life 20. So, the child's now beyond the first 2-week mortality zone.
Seems to have a mind problem.
Oh.
It'll allow you to do that.
Okay.
It's on. You can just speak into it.
Okay. The old-fashioned way. So this child was extubated day of life 20, has survived with hazardous first 2 weeks of life, and now at this point everyone can more or less hope for the best. Until about a week later, the child in the middle of the night produced one bloody stool, severe abdominal distension. This happened within the course of an hour. Abdominal X-ray demonstrates a lot of air in the bowel. Nasogastric tube was placed. Surgeons were called. Antibiotics were again started. The child was re-intubated. An X-ray was taken again a little after 8 in the morning. You can see a rim of air over to the right side of the abdomen there. This is called pneumatosis. It's gas in the wall of the bowel. It shouldn't be there. It's a highly ominous sign. The patient went to a laparotomy. This is what the bowel looked like. The surgeon mercifully didn't attempt to be a hero, said this is not amenable to an operation, and the child died several hours later. This child had a disorder called necrotizing enterocolitis. It's an acute inflammatory injury. It's not rare. About 5 to 10% of children born under 1,500 grams worldwide, decade after decade, will sustain grade 2 or grade 3 necrotizing enterocolitis. It is 30 to 40% fatal. The only difference between this and an anterior wall myocardial infarction in 2016 is that this disorder is about 10 times more lethal. Among the survivors, the 2/3 of the patients who survive, some do well, but many do not. It is an independent and fairly strong risk factor for later in life neurodevelopmental issues. The treatment is very crude and has not changed in 4 decades. Our ability to detect this disorder in advance of abdominal distension and clinical deterioration has not changed in this interval either. Effectively, the surgeons do laparotomy when indicated in about half the cases and see if there's anything to resect or not. If one were to try to approach necrotizing enterocolitis to figure out what is causing this disaster, go to a review article, and here are the suspects that have been variably put together over the years, and there's certainly a microbial flavor to this. Prematurity is an enduring risk factor for the development of necrotizing enterocolitis, and I think we can more or less assume that a preterm infant is going to have a different gut microbial population than a term infant in whom this disorder rarely develops. Formula feeds have been associated, though regrettably, despite the best attempts, the use of breast milk has not made this disease go away. H2 blockers, acid suppression is a risk factor. These are all, you can imagine, large database analyses. And prolonged antibiotics in most, but not all studies. These are prolonged antibiotics at birth. Beyond the 5 days are associated with the development of necrotizing enterocolitis over the next couple months. So with this, several years ago, in response to a demonstration project request for applications from the NIH, we entered a proposal to test the hypothesis that bacterial dysbiosis, defined as a community of microbes associated with an unfavorable outcome, precedes and thereby plausibly causes necrotizing enterocolitis. One of the concepts David just mentioned was if you're trying to associate something in an epidemiologic study and something that you weren't trying to put forward as causative, it's better to be there before the event than only at the event. Now, we have a lot of opportunities in looking at necrotizing enterocolitis. These children live in a managed ecosphere, not quite as well managed as Dr. Flake-Slams from Philadelphia, but these children are in incubators. The nurses do not wear gloves when they touch them. The parents do not wear gloves, but all other visitors wear gloves. This disorder occurs days of life 14 to 60. You don't have to wait several decades to see if somebody will become obese. So you have a horizon. You can reasonably anticipate an outcome, a little shorter than pregnancy, but it's not so unfeasible. It's exceptionally feasible to look at this. To look at biologics prior to the event and see if they are related to an event in a reasonably short period of time. The 5 to 10% attack rate is fairly appreciable, not 1 in 1,000. These children live in this venue for 2 to 4 months. They're not running around the community, and you have to pull them back for specimens. There's extensive metadata. One of the very good things about electronic medical records. If something happened, it was documented, you can retrieve it for years to come. And the specimen of interest, stool, is a relatively low-risk material to take possession of. But there are challenges. There is certainly the concern that this is an observational study. There were really no promising leads on which to build any highly robust hypotheses at the beginning of this disorder. And our biggest challenge was the normal. In any case control study, you have to have a normal, was not defined in this ecological sphere. So this is what happens at birth. The child is born, the bowel is full of meconium, and as we've just heard, it's either sterile or, quote, largely sterile. It's certainly not a vibrant replicating bacterial community in the meconium, or we would have discovered that years ago. And over the next hours to days, the meconium passes, and soon a variety of bacteria come in. There's gram-positive cocci, there's gram-negative rods. This is my rendition of the bacteria that are now going to be with you forever. There may be some turnover, there may be changes in proportion, but you will never have a sterile gut again after the first few days of life, and it's a fantastic opportunity to study the ecology of the in-migration of a population that we all thought was, we still think, is largely sterile. Others have tried to define this. For over a century, we relied on culture technology, and we all know that that has some value, but an awful lot of expense and may be inaccurate. We then went through a couple decades of gel-based PCR-derived work, where one gets patterns and barcodes, and that's pretty good for identifying diversity changes, but it is not very good for really enumerating the bacteria in a stool. It's very expensive to try to extract data from that technology. And it wasn't until about a decade ago, following the pioneering efforts of Dr. Relman, that we were able to go directly to this biomass and amplify from the stool and do a census to determine who's there. We chose to use 16S ribosomal RNA sequencing at the time. We began the study in the late, we approached 2010. This exploits the ribosomal RNA gene of bacteria, extract DNA from stool, prime it in one of multiple places, sequence between your primers directly from your amplicons, send it into a machine, and you will be able to get a number of reads to tell you who's there, what are the bacteria that are there. We use 454 sequencing technology. We have 6,000 to 7,000 reads per sample, and this was all referred to the ribosomal database. And then we started to take a few children who developed NAC and a few children who were controls, and nothing really jumped out. So at this point, we realized how important it was to thoroughly and deeply identify what is the normal in-migration of bacteria in the gut. So we assembled 58 preterm infants, gestational age is 23 to 33 weeks. So that was a bit of a challenge because a 23-week gestational age child has a very different biology than a 33-week gestational age child. There's a gradient of risk of necrotizing enterocolitis, but this is a diverse population of subjects. To try to reduce some of the confusion, we focused only on one center at first, St. Louis Children's Hospitals. We sequenced all schools the day of life 30 from these children, and then every 3 days thereafter, the day of life 60. This is the zone of risk of necrotizing enterocolitis. 922 samples, an average of 7,000 reads per sample. This is what we got. We take all the schools, 922 schools, 58 subjects, and we say, what bacteria are there overall? 20% bacilli. Bacilli, I think, would be gram-negative rods, but in fact they're gram-positive cocci. Gamma proteobacteria are the gram-negative rods, and Clostridia. There were multiple species within this, but the ribosomal database was able to crank out mostly bacteria we would all recognize. Now, if we gave everybody in this room a cup and everyone pooped and deposited it on the way out, when we sequenced the normal adult or older child population, it's a very different distribution. Gram-positives are there, but they're less common. Gamma proteobacteria, gram-negative bacteria, are actually rather low proportion in normal, healthy gut, and Clostridia are of higher proportion. Anaerobes are higher proportion. So that was the first rather high-level change we observed we had to deal with. Then we tried to look at interspecimen variability. This is another way to plot out data in multi-dimensions. The three taxa, Clostridia, Gamma proteobacteria, and bacilli, those three made up 93% of all the bacteria present in all the stool samples. And if you look at this plot, you look at the arrowheads, if your stool is a dot near a bacilli in the lower left-hand corner, that means your stool is largely bacilli. Lower left-hand corner will be gamma proteobacteria or gram-negatives. And up in the upper right-hand corner, you have a dot there. That means your stool is largely Clostridia, but it will be a blend of all. And there's not a tremendous amount of sense that can be made out of this. The color codes here are days of life. And if you really squint, you really imagine, you say, well, there's a lot more blues towards the lower left-hand corner. These are the earliest children specimens. There's more polychromatic colors up towards the Clostridia, and it's still not very clear, at least at the level of the 922 samples that we put together. This is a single child who's actually rather prototypical, and most of the other single children we looked at did not have anywhere near as clear a progression as this child. So here are some of the challenges. Then we're trying to define the control group. Stools, even though they're a very safe specimen to handle, are produced when the child wants to produce them. You can't schedule a blood draw and say, okay, what is your weekly cholesterol level? So there's random stool days. The other challenge here is that there is a progression of bacteria. So earliest in life, a lot of blues here, a lot of bacilli. Next couple weeks, a lot of gram-negative bacteria. And this child, the organisms were largely E. coli, a subset of Klebsiella and Enterobacter. And then at around 30, 40 days of age, this child's stools began to start to become more abundant in anaerobes. So you see gram-positives, gram-negatives, anaerobes, a form of ecological succession, as David just described. So that sounds nice and clean, except there's a few little hiccups here. So second specimen, I think it's day of life 4, this child wants to all of a sudden knock down its gram-positives and found a few anaerobes to fill up the space and a lot of gram-negatives, but they didn't last. Several weeks later, this child tried to have a recovery of the